our guests the trouble and the stress that surrounded this adorable little girl's birth, the heart complications her mom is still dealing with today. Good morning, I'm Alexis Del Cid. Welcome back to All Things Heart. Pregnancy-related heart failure. It is something that happens in up to 1 out of every 1,000 pregnancies. We talk about the risks, how to identify it, and how to treat it, most importantly. But first, we're going to kick off our program with something that also affects expectant moms. In today's morning rounds, we're talking about RSV season. It is almost here. The American College of Obstetricians and Gynecologists recommends that if you're pregnant, you should get the RSV vaccine between 32 weeks and 36 weeks. Joining us today to talk about this is pediatric critical care specialist Dr. Sean Sood. Dr. Sood, thank you for joining us. The NIH says children infected with RSV at a young age increases the risk of them developing asthma later in life. Does this include if their mom gets RSV when she's pregnant?
Yeah, so if a mom is pregnant and gets RSV, she has the potential for pregnancy-related complications such as preterm delivery, but it does not increase the risk of the fetus developing asthma later in life. Those studies with a link between RSV and asthma are related to the direct exposure of a child after birth getting exposed to RSV and then later on developing asthma, not an indirect link during pregnancy when it's passed through the placenta.
Got it. So does the mom getting vaccinated pass on the immunities through the placenta?
Yeah, absolutely, and very, very effectively. So there's a RSV maternal vaccine developed by Pfizer. It's available for pregnant moms, just like you showed on the slide, who are 32 to 36 weeks pregnant, and it can pass on protection to their baby. Basically, with a vaccine, your body responds by making a protein that protects against the virus that causes RSV. This process of your body making that protein or an antibody takes about 2 weeks. So babies who are born at least 2 weeks after their mother gets RSV vaccine are protected at birth when infants are at the higher risk of severe RSV disease. This vaccine is so effective, it can reduce the risk of being hospitalized by that child by more than 57% in the first 6 months after birth. And it can reduce the risk of severe RSV disease by 82% within 3 months after birth. So it's a very effective vaccine.
So if, God forbid, someone is watching and their baby gets RSV, or their child gets RSV, what is the connection between RSV and then years later developing asthma?
Yeah, there is a direct link that researchers have found. And so more than 50,000 young children are hospitalized here in the United States alone with RSV every year. And infection with RSV at a young age is thought to increase the risk of developing asthma later in life. And for our viewers, asthma is a chronic condition that can cause your lungs to become inflamed or more narrow, making it more difficult to breathe. And about 1 in 13 citizens here in the U.S. have asthma. And so researchers show that out of that whole cohort of asthmatics in this country, about 15% of them could be prevented if they weren't exposed to RSV during a young age. And so why that happens is, you know, when a child is infected with RSV within their first year of life, their lungs and immune system are still developing. And the thought is that exposure to RSV could lead to certain abnormalities that can later cause asthma later in life.
That's super interesting. A lot of us old people are wondering maybe if we got RSV as kids and, or, you know, they didn't have these things available 50 years ago. What is peak season for RSV? And then when can someone get vaccinated for it? What's the age range?
Sure. Peak season is December to February. And so that's when, you know, I work in the pediatric ICU. We see a huge uptick in admissions. And you get vaccinated. There's 3 cohorts of people that can get vaccinated. So adults age 60 or older can get vaccinated with the RSV vaccine that can help prevent severe disease. There are actually infants and newborns that can get immunized with antibodies to RSV, but pertinent to the show today, it's really pregnant moms who are between 32 and 36 weeks pregnant, really between the months of September through January. I highly encourage them to talk to their gynecologist, OBGYN, and see if a vaccine is the right choice for them.
Dr. Sood, thank you so much for taking time to join us. We know you're busy and you have patients, little patients to go tend to, so thank you. We'll cut you loose now.
Thank you.
We want you back. Now to the topic of pregnancy-related heart failure, which sounds terrifying. Veronica Rodriguez-Mendez was pregnant with her second baby. She was just soaking up those last few weeks, enjoying things. Then her pregnancy was cut short when she found herself in the intensive care unit at 7.5 months.
Homegirl is teething.
With her big brown eyes and infectious giggle, baby Liliana is living her best life.
She's doing all the things she's supposed to be doing as a 7-month-old.
But the stress leading up to her birth is something Mom and Dad will never forget, including the frightening diagnosis that came when Veronica Rodriguez-Mendez was 33 weeks pregnant with the couple's second baby.
Pregnancy-induced heart failure.
Pregnancy-induced heart failure at 35 years old with no prior history of any heart problems.
We were shocked. It was very unbelievable. One would never expect we would be dealing with a condition like this.
Veronica says it started with fatigue that progressed into more alarming symptoms.
I just felt like I was drowning whenever I laid back, and then my heart was just going a mile a minute.
After one particularly bad night, she went to her OBGYN, who sent her to the emergency department near their home in Lawrence. And from there, she was rushed to the University of Kansas Health System by ambulance.
Which was also bizarre, because usually you see them pass by, you don't usually imagine yourself inside of one.
It was here the couple says that they met the two doctors that played crucial roles in saving Veronica and Liliana. Heart failure and transplantation cardiologist Dr. Paola Roldan and cardiologist and electrophysiologist Dr. Ria Pimentel.
They're just incredible human beings.
And a huge added bonus,
they're probably aware of what it means to be a woman of color navigating the health system.
I did notice the immediate connection between Veronica and them.
Makes a difference, because I know that's something that they understand. I knew I was in good hands, but I have two just incredible women on my team.
A team that would lead her through a drastically different birth plan than what she'd envisioned. Liliana would be delivered via C-section at 33 weeks in the cardiothoracic surgery unit.
The other thing is that Dr. Roldan speaks Spanish, and my mom had flew in from Puerto Rico at that time.
An experience so stressful, yet because of Dr. Roldan and Pimentel, Veronica and Joel say it's one they now talk about with joy. And 7 months later,
we're just living life of busy parents for the most part, with kids who seem to have a more busy social life than we do. So there is no stopping this train.
Spoken like a true busy mom, Veronica joins us in studio today, looking fantastic, if I might add, along with her cardiologist, Dr. Paola Roldan. Dr. Roldan specializes in cardio obstetrics. We are missing one half of our dynamic duo. Dr. Pimentel could not join us today, but she sends her love, and she is so thrilled that you and your baby are doing so well. Veronica, when we last talked, you were still in heart failure. What's the status now?
Yeah, so improving, just really working to make sure that my ejection fraction continues to rise, and it's trending up. So hopefully we stay in that course, and hopefully I'll be recovered at some point here soon, which is a possibility with my condition. So I'm really
which is great. I want to bring in Dr. Roldan quickly. We talk about ejection fraction a lot.
Yeah.
Is there a simple way to explain to our viewers what is ejection fraction?
Yes, it's a very common question. So when we think about ejection fraction, we're talking in regards to the left chamber of the heart. And the left chamber of the heart is the big pumping chamber of the heart. We've got the right side and the left side. And they work very much together, but when we're talking about the ejection fraction, we're typically talking about the left side of the heart. And if you can think about a bucket, you start with an amount at the filling phase is what we call it.
Okay.
And then if you squeeze the bucket, we call it kind of the pumping phase. And so the ejection fraction is what you start off with minus what you end up with divided by what you started with. And so, for instance, if we started with 100 and we end up with 50, divided by 100, that would be about 50%, right? So that's what we're talking about when we talk about the ejection fraction. It's how much your heart beats with each beat.
So you want that to be a high number.
You want it to be, a normal ejection fraction is between 55 to 70%.
Got it.
Below 55 is considered reduced. Above 70 is considered hyperdynamic.
Got it.
Yes.
And so you had a very low and still are doing things to make sure your ejection fraction stays up. What's your treatment plan?
Well, honestly, I am taking medicines. I had, which have been great, and then they continue to kind of increase as I feel well and manage those well. And then I also have an implanted defibrillator, just in case. If I need it, it will be there. And so that's really a really helpful kind of peace of mind. In addition to, I did cardiac rehab, which was really helpful in terms of gaining confidence in my body and what my body could do, especially
Right.
after such like a big event where you don't know how much can I do after this.
And unexpected.
Yes,
So you're
absolutely.
frightened that your body can betray you like that.
Yes.
What happens in cardiac rehab? You jogging and doing exercises and what it sounds like, rehabbing part of your body, but it's your heart?
Yes, 100%. But I think there's an added element where they track how your heart is doing while you do that. So you kind of know it's doing well. And so
Right.
knowing and seeing that it's doing well really gives kind of like that peace of mind. Okay, I can do this now, or I can do more. Because initially, I think there's a little bit of worry where, am I doing too much?
Right.
Where it could be like a problem, and I think that also really helped in like, oh, my body can handle it, my heart can handle it, and so I think that was also really helpful.
And worrying about doing too much when you have 2 kids under the age of 5 at home, that's a worry probably for every mom that has 2 littles. Do you have any limitations? You talked about getting out of breath and being so exhausted. Have those symptoms gone away?
No, I think that there's always going to be fatigue with kiddos. But honestly, I do think that sometimes, like for example, if I'm in the heat for a long time or standing up or doing too much, maybe the next day I feel a little bit more tired. But I think the biggest thing that kind of remains is kind of this sense of breathlessness if I'm going upstairs or up a hill where I'm like, oh my goodness, that was a challenge, or maybe, but usually it goes back and I just need to take a minute and go back to my business or whatever I was doing.
So I want to bring Dr. Roldan in.
Yeah.
Help us to understand what exactly is happening to your heart during pregnancy-related heart failure, which is also known as, it has a long official name, peripartum cardiomyopathy, but that's pregnancy-related heart failure.
Yeah.
What's going on?
Yeah, so there's normal physiological changes that happen with pregnancy, right? You go from supplying blood and volume for 1 person then to 2 individuals, right? So there's some normal physiological changes that happen with pregnancy. You can start seeing on normal pregnancies that your heart gets a little bit dilated.
And we do have an illustration we can put up while you're explaining this.
Yeah. And so again, in a normal pregnancy, you might see on a normal echocardiogram that it's a little bit dilated because it's having to carry more volume.
And which image is the one that would resemble Veronica's heart when she was at her sickest?
Yeah, so the normal heart is on the left.
Got it.
And that's a normal size, normal functioning heart. The one that is similar to Veronica's would be the one on the right, where it's a dilated heart. And so what happens in what we call peripartum cardiomyopathy, or even sometimes called postpartum cardiomyopathy, is that there is, and I will say that the exact reason why some patients develop it is not well understood. We do understand that there are some risk factors, but what physiologically happens is that there is an excess of dopamine release, which is something that our brain releases naturally during pregnancy as well as during breastfeeding. And that causes some downward pathway effects that essentially cause the vasculature to change and the heart muscle to change. There's also some concern that perhaps fetus is also secreting a peptide that also causes some malformations of the heart. So there's several pathways that contribute to what we think is a pathophysiology. We're still learning so much about this disease process.
So stressful for mom, but does it stress you out when a mom comes in a dire condition like Veronica? I know you're obviously brilliant, professional, you helped save her life, but when you first see this mom come in, 7.5 months, does your heart start pounding?
Yeah, I definitely don't desire any of my patients to be sick ever, right? But I do feel like it's a complete privilege to be able to take care of patients like Veronica, because they're at their most vulnerable state, right? They're pregnant, they're also very sick, and so it's definitely something that I'm extremely passionate about. And thankfully here at KU we have a huge pregnancy heart team that also really cares and loves on these patients like Veronica. And we know that the mortality rates and the complication rates in the United States with pregnancy is much higher in the United States than it should be. And so I think we're more aware that we need to start building teams that can take care of patients like Veronica and Ileana, so that we can see that they progress in the right direction.
Was there any way to treat her with anything before deciding time to deliver the baby early?
So we love to be able to progress mommy and baby to as long as they can in gestational age. And so Veronica, she came in around 33 weeks. 34 weeks is kind of when we're like, okay, baby is doing all right. Ideally we could get them to 37 weeks is what my MFM team talks about. I will not pretend like I'm an OB.
And what does MFN stand for?
Yes, so maternal fetal medicine. They are the backbone of the OBGYN team that take care of high-risk patients, meaning patients who may have cardiac disease or other type of diseases going into pregnancy. In regards to why we decided to take Veronica for a C-section is her heart was very sick and her heart was racing very fast. And the idea is if we can't keep mommy safe, then we can't keep baby safe.
Right.
And so we were in a situation where we wanted to take care of mommy and baby, and so the best decision for her was to proceed with a more urgent C-section so that we can take care of baby, but then we can also put mommy on medications that are going to get her heart stronger over time.
One of the things that seems hard to figure out, because here you are 7.5 months pregnant, you're also chasing after a 3-year-old in your house. Of course you're exhausted.
Yeah.
Yet, Dr. Roldan, exhaustion is a symptom of pregnancy-related heart failure. How does the exhausted mom watching this on her phone or her computer right now know the difference between, oh, I'm just exhausted and I'm in heart failure?
Yeah, it's so hard. Because a lot of the symptoms that Veronica developed are very typical when you enter the 3rd trimester in pregnancy, which is usually the time that patients can present with peripartum cardiomyopathy. It's usually within that last trimester or 6 to 8 weeks, typically after birth. And so these are, again, symptoms that most patients with pregnancy develop. They're tired, they're short of breath, they've got leg swelling. I would say to the audience, if there's any concern that you think that, hey, this just seems out of my prior pregnancy norm, or I'm a new mommy and I just don't understand, what's going on, seek help.
The worst that happens is they tell you it's pregnancy.
Completely normal.
The best that happens is you catch something and fix it. Veronica, did you have any genetic predisposition to this? Did this run in your family?
We found out not at all, really. And
so is it just bad luck, Dr. Roldan?
Yeah, so as I mentioned, there are some known risk factors for peripartum cardiomyopathy. Some of them include your ethnicity. So Black population, Native American population, Hispanic population are more prone to this. Those that have multi-parity or multiple pregnancies. Those that have gestational diabetes. Preeclampsia is also a huge one, which Veronica did present with what we called, low risk preeclampsia. And then the other one that we think about is a genetic predisposition. So we did test Veronica for that.
Yeah.
There are certain mutations that can run in the family that can predispose someone to having peripartum cardiomyopathy.
Do we know yet why certain populations are more at risk? Veronica is Hispanic.
Yeah.
You said the Hispanic population,
Yeah.
but why?
Yeah, it's a great question. The answer, we don't think we understand why. I will say that some populations are more prone to preeclampsia,
Got it.
which is essentially high blood pressure in pregnancy that causes potentially liver dysfunction, as well as what we call kidney dysfunction. It makes you spill out protein. So there's a certain geographical variation. What I will say is it's very common in Nigeria as well as in Haiti. It occurs in 1 in 100 pregnancies.
Oh, wow.
In the United States, it's more in 1 in 1,000 to 2,000, and then in Japan, it's 1 in 10,000 pregnancies. So there is some geographical variation, which isn't isolated just to peripartum cardiomyopathy. There are some other disease processes that happen in other populations more than the other. We're
a lot
learning
of people
so much.
Go on.
We're just learning so much
Yeah,
about this
constantly.
disease
That's
process. Yeah.
science. It's
Yeah.
evolving. Medicine's evolving.
Yes.
Everyone wants to know, how is baby Liliana doing today?
Oh, she's great. She's a happy baby, which is super social, super giggly. She's teething right now, so maybe not at her happiest.
Right.
But she's growing and doing great with all those cute little baby rolls. So it's
Those
she's awesome.
chunky thighs.
Oh,
You're talking
they're
about the
the
rolls.
best.
You squeeze them. How is her big sister handling her new role?
Oh, she's great. We constantly telling her how great of a sister, because now she's crawling and experimenting with things and going after things. And Sophia's like, wait, don't touch that.
Oh, so she's her protector. I love that. Sophia's 4.
Sophia's 4.
Okay.
So she's also helping us baby-proof the house, making sure the baby's doing great.
Oh, so she's really enjoying her role.
Oh, 100%.
She'll be a good babysitter. We already have questions coming in from our viewers. We're going to get to the viewer questions in a minute. If you have a question or comment, these are the links where you can send them to us in real time throughout the program. YouTube, Facebook, the All Things Heart email. Use any of those links and we will answer your questions or read your comments on air in real time. Dr. Roldan, is there anything women can do to minimize their risk of developing this?
Yeah, so one thing that we should talk about is, making sure that you're, one, aware of your body, which, Veronica was very much aware of her body. The other thing is just regular checkups with your OBGYN team so that they can monitor for gestational diabetes and they can monitor for preeclampsia and they can monitor for some of these risk factors. And then again, if you are of Black ethnicity, Native American, or Hispanic, I just want them to be more aware that, again, they might be more prone to this disease process than other ethnicities. So I think just awareness and then constant communication with your OBGYN team is extremely important.
Veronica, we want to talk about your birth plan, which went out the window real fast. How was it described to you in the moment that we're gonna need a new plan?
Yeah.
I mean, they were honestly trying to get me to at least 34 weeks, and I think the whole time the team was trying to see how long we can make sure that the baby can safely stay there and develop. And I think as progressed, I know they would tell me we met today to talk about, and so that will keep me updated. But I think we took it really step by step, and I was really open as long as I was safe and my baby was safe. And honestly, that's the route we went to, and clearly we're both here and we're both safe and doing well, and so
the right choices were made.
We have a picture of Liliana and you after birth. Were you able to hold her right away? I love this picture.
I think it was later, it was about 24-ish hours in that recovery, but they were all so sweet because I was like, oh, I wish I could see my baby. And the nursing team and the doctor went himself with me so I could see the baby and be able to hold her. Because I think there's something about not being able to see your baby and hold her right away.
You're in the next room and you're, you were sent home then finally with baby, but also with a very strange looking, if you haven't seen it before, something called a life vest. We want to show a picture of the life vest. Now, how long did you have to wear this for?
It was about 3 or 4 months that I had to wear it. Some folks wear it longer than that.
You had to sleep in that.
I had to sleep in everything during my day. I would be wearing that, except when I took a shower, essentially.
You're nursing, you have to, could you nurse wearing that?
Actually, I was not able to nurse because I wanted to prioritize being able to take the best medicines possible. But I was able to pump for a period of time. And, I got support around that. But otherwise, I would be able to carry the baby and be mobile and do all the things that I could do. It was strange. It was a little bit of a shock when you're getting fitted for that.
Right. This is going to have to go under all your cute clothes. And no matter what you do, you've got to sleep in it. Real quick, because we have a moment I want to share in 1 second, but what does the life vest do?
Yeah, so the life vest is essentially what we call an external defibrillator. And so as Veronica mentioned earlier, she now has an internal defibrillator. And what a defibrillator is it monitors to see if you have any abnormal heart rhythms and if you have what we call a life-threatening arrhythmia. And those are what we call bottom chamber arrhythmias. If you have something that looks like a life-threatening arrhythmia, it will shock you out of it. And for Veronica, based off of the guidelines that we have in America as well as in the European guidelines, because her pump function was less than 35%, as we talked about in the beginning, she qualified for what we call a life vest. And that's what she was describing as a external defibrillator that monitors your heart and shocks you if you have anything that could be life-threatening.
One of the things we talked a lot about when we first met you and I talked on the phone is family, and we want to share with our audience this sweet moment that your husband describes to us, what he thinks about you.
I think she's a very optimistic person, very kind-hearted. I think she's more than anyone can ask for.
Right, that was just a little snippet of how he just glows about you. Clearly you have a guy that adores you. How much did family mean to you recovering from this?
Everything. I think he was also there every step of the way. Every appointment with Dr. Roldan, he was there. And so that support was incredible, and I had a lot of family who came and helped with the baby as I was recovering, or helping cook and do all the things that that you have there. But I think even culturally, family is important. But imagine being in a situation where you're recovering from an event like this. Family becomes the center of that recovery process if you're lucky enough to have one.
Right. You're a lucky mom, lucky woman. And we're gonna, I have a question for you about her mom in a second. But first we have some questions from our community coming in. The first one is from Yen Liang. Yen wants to know, could you explain the common causes that lead to excessive cardiac strain or even heart failure in pregnant women? So the most common causes, do you know any?
Yeah, so I guess if I'm understanding the question correctly, she's kind of talking broadly about other disease processes.
Excessive cardiac strain. Yeah. So it sounds broad.
Yeah. So I would say, the big things that we think about that can cause or predispose patients to having, again, the condition that Veronica has is, again, the gestational diabetes as well as preeclampsia or gestational hypertension or being of the certain ethnicities. But if we're thinking kind of broadly, so let's say that we are dealing with a different patient that has a known structural heart issue. Right. So for instance, my partner in crime is Dr. Surface in the cardio-obstetrics clinic, and he is an adult congenital heart disease doctor. And so he deals with a lot of patients that were born with heart defects. And I take care of patients that have a predisposition or have heart failure. And so if you're going into pregnancy with already an existing structural heart issue, those are patients that need to be closely monitored, because it doesn't take very much to tip them over the edge in pregnancy, because again, they're taking care of now just not one person, but two people.
Two hearts.
Yes.
Marie wants to know, and this is what I want to know too.
Yes.
What was it like the moment Dr. Roldan comes in and starts speaking Spanish, just rattling off medical terms to your mom, who just came in from Puerto Rico?
My mom was like, wait a minute, your doctor's Latina and she can speak Spanish. I think initially it's like, oh, this is going to be great. I'm going to feel more included in this process, which I think sometimes when language access is not necessarily as readily available, is not something that maybe folks could feel like they can be a part of the process. And so have somebody there who could do that for us and to also provide some familiarity to this very foreign process for a family. And I think that felt a lot. And honestly, representation matters. I think for me, it felt very comfortable from the beginning to have Dr. Roldan be my medical provider still as well. And so I think moving forward, I think my family is just super grateful to have her be my medical provider, and they still talk about you, Dr. Roldan.
I loved seeing Dr. Roldan came in, and she and Veronica went right to each other's arms and started hugging, which we love to see. And as we get some final thoughts from both of you, I want to again go back to what Veronica is saying, is that you talked a lot to us about the importance of being cared for by a team that shares the same background or culture or that looks like you. Can you share with our viewers what a profound difference that makes in your recovery and your trips to the doctor during such a stressful time? And I know you've already been sharing that with us, but you said you've never had your entire care team be all women of color.
Honestly, that hasn't happened.
And it happened this time.
And it was something that I do not take for granted. At any point in this. And I think sometimes even in my head I know that, especially for maternal health and women of color, there's usually other risks and other things that we have to think about medically, and to know that we have women that whether they've gone through that themselves or understand that is present, and navigating the health system for women of color may feel different in terms of being heard or seen. And that's never something that I had to doubt with Dr. Roldan in my care, in charge of my care, because I always felt seen and I always felt heard.
Dr. Roldan, you've been nodding your head yes this whole time. How does it feel to know that you are making that difference with not just the patient sitting to your right, but so many women?
Yeah, I mean, gosh, I feel very emotional just sitting next to Veronica, because again, she walked through a very scary and vulnerable time in her life, and I'm just so thankful that even my ethnicity and my ability to speak Spanish was a comforting aspect to her. And I think that's, for all the physicians that took care of her, which, gosh, if I tried to name all of them that were involved in her care, I mean, we would go down to 9 o'clock, and we just don't have enough time. But I mean, everybody was so important in her care. And, the way that we can connect with patients is not just through common experiences, ethnicity, spiritual beliefs, but I think that's the goal of a doctor, is to see how we can connect to our patients, not just from an intellectual aspect, but how can we make them feel even a teeny tiny bit safer.
You're using every single tool in your toolbox.
Yeah.
Medicine, bedside manner, ways to connect. That you described what every brilliant doctor says who has a patient that loves them so much. We love sharing the incredible heroics that our team of doctors here at the health system does, but have you ever wondered what your doctor does outside of work?
Now for a secret look into the guardians of healthcare at the University of Kansas Health System, let's go behind the mask.
Dr. Roldan, when you're not working, you're working out. By the time you have started seeing patients here in the morning, you've already been awake for several hours. What time do you wake up?
Usually wake up anywhere between 4:30 to 5, and
the first thing you do is Exercise.
Yeah, I read my Bible for a little bit, I pray a little bit, and then I get working out. And it's just such a privilege to be able to move your body, and I definitely don't take that for granted, and definitely encourage my patients as much as they can to do the same. You
started this very rigorous program, is what I call it, because you're up at 4:30 during medical school, though, at a time when you're already, I would imagine, not getting a lot of sleep. So how did that help you throughout medical school?
Yeah, so I think mental health, I think, is something that's just so important, and when you're in the fire hydrant of medical school is what we call it, because it does feel like
drinking from a fire hydrant.
Yes, drinking from a fire hydrant. To have your mental health is really important, and so again, I don't take it for granted, the ability to move my body, and so it started. I mean, even before that, my parents always emphasized the importance of exercise. So even before medical school, it was a crucial part of my life.
Well, thank you for sharing that part of your life with us and sharing your amazing journey. And thank you for taking the time to be with us this morning. Veronica, thank you for sharing your story with us.
And thank you to everybody who made sure that I was taken care of, and every single person who was part of that journey, from doctors, nurses, APRNs, you name it. Yeah. Just so grateful.
Takes a village.
Yes.
Takes a village. Coming up next week on All Things Heart. Instead of driving hours to find the right doctor, Glenn Verdon only has to drive 15 minutes in a town of less than 3,000. We share the work being done to make sure people in rural communities have the same access to excellent health care. That's next Thursday at 8 a.m.
Coming up tomorrow on the Morning Medical Update. Diagnosed with not one, but 2 cancers at the height of the COVID pandemic, all while caring for her 2-year-old grandchild. I'm Jessica Lovell on the next Morning Medical Update. We ask Ava Neal where she found the strength to endure both breast and ovarian cancer, plus what women should know about risk factors. Friday at 8.